Good morning, everyone. It's my pleasure to be here, and I would like to thank the organizer for inviting me for this presentation. So I'm going to present to you the first and second line treatment for EGFR-mutated positive tumors. These are my conflict of interest. We start with a little bit of epidemiology of EGFR mutations. As you know, EGFR mutations account in Caucasian patients for around 10% of the patient. This study is the biomarker reference study presented by Fabrice Barlesi. You see the same representation in overall population and adenocarcinoma because this was a population that was tested for molecular markers, so thus biased as being chosen with adenocarcinoma. But we see that the EGFR mutation is more frequent in women in this population as around 20% and much more frequent in never smokers as being around 44%. The worldwide distribution shows various representation around the world. As you know, EGFR mutations are more frequent in Asian population than in Caucasian population and are a bit in between in the North America population because they have a quite important migration from Asian countries. So the prevalence is shown here, around 45% in Asian and Pacific Islander, 24% in Caucasian, and 29% in Black patients. Of course, a higher prevalence in women than in men, both in Asian and non-Asian patients, but still more prevalent in Asian. More frequent, way more frequent in never smokers and in smokers, and also way more frequent in adenocarcinoma than in other histologies. And the pathways that EGFR are activating are multiple. They include KRAS pathway, which is, of course, therefore, one of the resistance mechanisms, the STAT signaling, and also the PI3K pathway with AKT and mTOR. There are different mutations that are known in lung cancer. The most frequent are in exon 19 with a deletion of exon 19, and in exon 21, the most frequent is called LA58R. But there are also mutations known in exon 18 and in exon 20, and the most frequently known in exon 20 is the resistance mechanism mutation, which is called T790M. What do we do in first-line therapeutics for EGFR mutant? I think you know about that, so I'm going to go quite quick on this part and move on the most interesting part afterwards. So the first drug that was demonstrated to give benefit in this patient is gefitinib. It was IPASS trial published in 2009 by Mock. This very famous trial was the first one to demonstrate that the mutation status was very important in our decision treatment for our patient, as you can see on the right side, that for EGFR mutation positive patient was a clear benefit of choosing gefitinib in first line compared to platinum doublet with a hazard ratio around 0.48, and at the opposite for EGFR mutation negative patient, the gefitinib should not be chosen as chemotherapy was better for this patient. So this was the first observation in this way. There were many others that followed this study. The second drug that was studied is erlotinib in the ERTAC trial in 2012, published by Russell, but demonstrating exactly the same thing in EGFR mutant patient, a clear benefit of choosing erlotinib compared to a platinum doublet. And finally, the third drug is afatinib in LUX-Lung 3 in 2013, showing again the benefits for using afatinib compared to a doublet of platinum in patients with EGFR mutation. So this is now clearly established by 8 phase 3 randomized trials that we should choose in first line one of these 3 drugs, so gefitinib, erlotinib, or afatinib, when a patient is presenting an EGFR sensitizing mutation, so mainly EGFR exon 19 deletion or exon 21 point mutation. You see across these 8 trials that they are mainly dealing with Asian patients, of course, because these mutations are frequent in this population, but they are also dealing with Caucasian or mixed population. That whatever the drug, you have a response rate between 60 and 70%. Whatever the drug, the PFS, the median PFS will vary between 9 and 11 months, and that the hazard ratio for the PFS are always around 0.40. So these studies are very consistent. So what should we choose between the drug? I tell you we have 3 drugs. So overall, gefitinib is really equal to erlotinib. You see this trial of 256 patients. You see that erlotinib was not superior to gefitinib in PFS or in OS. The curves are completely overlapped. And there was also no difference in toxicity profile between the drugs. And there was also no difference whatever you were looking into details for the different mutation. For deletion 19, slightly better OS, but equal PFS. Anyway, those drugs are considered as being equal. What about afatinib compared to first-generation TKI? So here there is a LUX-Lung 7 trial, a phase 2b trial that compared afatinib to gefitinib in first line for EGFR sensitizing mutation. So this was a negative study as one of the 3 co-primary endpoints was not met. You can see here that there is no difference in OS between the 2 drugs, and this is confirmed whatever you have a deletion of the exon 19 or a point mutation of the exon 21, so it doesn't depend on the type of mutation you have. However, updated results showed that there is a little difference in PFS between the 2 drugs with a little advantage for afatinib compared to gefitinib. And this was also confirmed in time to failure. And the updated odds ratio for response also showed a benefit in afatinib with 73 versus 56% of response. So there is a slight benefit. However, the survival wasn't different. So it's debatable if you should choose afatinib versus erlotinib. I would say that the 3 drugs so far are equal. So the 2 drugs are quite equal, but the EGFR mutation are not equal. So I said the most frequent mutations are found in deletion of exon 19 or a point mutation of exon 21, but there are many other mutations that are less frequent, but that you will see in your clinic, in your patient. And when you see such mutation, you need to know what to do. So there are mutations in the exon 18, and the most frequent is G719X. There are some mutations that are different than the point mutation L858R in exon 21, and there are also insertion in exon 20. So what are you doing with these patients? So these are in vitro results, and you don't need to look into the details of the numbers. The colors are representing the sensitivity of the different mutation to the different drugs. You have first, second, and third generation in the 3 columns. So when it's blue, overall, it means that it's okay, it's working. When it's yellow, it's not so good, and when it's red, it's really poor. So what you can observe is that there is a slight difference for deletion 19 and exon 21 common mutation for response to first generation EGFR TKI. Deletion 19 does slightly better than the exon 21 point mutation. But mainly what you see is that for the exon 18 mutation, you should not use first generation EGFR TKI. You should use the second generation, which means afatinib. And what you see clearly as well is that for the T790M, none of them should be used. You should go directly to the third generation drug. Another representation of the equality or not of this EGFR mutation. This is based on clinical trial, not anymore on in vitro results. And what you can observe is that clearly when you have those rare mutation, the response rate that you've seen in the 2 first trials that were around 60 or 70% and not anymore the same, it's much lower. The deletion of exon 19 in the first line is 25%, and the others are varying between 30% and even sometimes really lower. So that's not the same. You don't expect the same sensitivity to the first and the second generation EGFR TKI drug when you have those rare mutations. Why am I back to this one? Okay, so there is also a posthoc analysis of LUX-Lung 236, even if we know that posthoc analysis needs to be taken with careful thought. They divided the mutation in 3 groups. The first mutation group was point mutation or duplication in exon 18 and 21. Then they had a group with the de novo T790M mutation, and then they had the third group with the exon 20 insertion. What came out of this is that only the first group was really having a benefit from afatinib. And they went deeper into the details of the mutation, and you can see that only the first one gives really significant results, which is a mutation inside the exon 18. So we may recommend when you have an 18 insertion, deletion, or whatever type of mutation in exon 18 to use afatinib instead of the first generation EGFR TKI. So if I need to summarize this, so when you have an exon 19 or exon 21 classical mutation, you can use whatever the TKI first or second generation in first line. When you have the more rare mutation like the G790X, which is an exon 19, you can use TKI second generation rather than first generation. If it is the T790M mutation, you go directly for third generation. And if you have the exon 21L861Q mutation, you can use whatever first or second generation. For the other mutations that are very rare, we really don't know what to recommend. So what else could we do in first line for EGFR TKI? We could associate them with anti-angiogenic drug, or we could associate them with cetuximab. This is a trial associating erlotinib with bevacizumab, or compared to erlotinib alone. This is a phase 1 in first line, and the results show kind of a benefit for the association compared to erlotinib alone. The PFS was 16 months compared to 9.7 with the hazard ratio at 0.54. So I can say that these results are quite encouraging for this association. This needs to be confirmed, of course. There are 2 phase 2 trial single arm that are showing comparable results, and therefore EMA approved the combination of erlotinib and bevacizumab in April 2016. I don't know how it is in your country, but I can tell you that in France, where I'm working, EMA approval is there. We don't have the reimbursement of the drug, so we cannot prescribe the combination. So the other association that would be a good idea to try is the combination of afatinib and cetuximab. It has been demonstrated in vitro that it can overcome resistance and so delay the apparition of the resistance to first-line EGFR TKI or second-line EGFR TKI. So you see here quite a nice waterfall plot showing responses. And there is now a trial in the IFCT in France, which is the ACE trial, a phase 2 trial, comparing afatinib alone with afatinib cetuximab for the 6 months at the start. And there is another trial doing the same comparison in the US that is ongoing as well. So we don't have the response, but this is still a potentially interesting combination. What do we do in the second line? Unfortunately, even if we have very nice response rate and even if we have amazing response compared to chemotherapy for this patient, you know that they will all relapse at some point and that the PFS is always around 9 months. So what are the mechanisms of resistance? They're well known right now. The most frequent mechanism of resistance is a T790M mutation in exon 20. It represents around 60% of the mechanism of the resistance. The other mechanisms include HR2 amplification, MET amplification, also transformation in small cell, and combination of these various mechanisms. So what happened in the T790M mutation? In fact, the threonine that was the gatekeeper residue and that lies in the back of the ATP KIs binding pocket, so the key pocket for the mechanism of activation of the downstream protein, is replaced by a bulkier, so bigger methionine, and this is blocking the drug that cannot bind anymore in the site. So different drugs have been developed that are called EGFR TKI of the third generation that are designed to be able to fit in this new bulkier pocket, and that therefore will be active even if T790M mutation is present. They have been developed to have a very high selectivity for the T790M mutated EGFR cell lines and not to be active against wild type. You can see that in different parts of this figure. And their activity has been confirmed. First, in phase 1 trial, so the AZD9291, you know, is the osimertinib drug, also called Tagrisso right now, and demonstrated very high activity with response rates of 61% in phase 1 and PFS of 9.6 months, and afterwards confirmed in phase 2 with 70% of response rate and 9.1 months of response. Those are results for patients presenting the T790M mutation. Therefore, it has been approved both by FDA and EMA, and we can now prescribe it for our patient. This is the phase 3 trial confirming and comparing now osimertinib to pemetrexed and association of carboplatin or cisplatin in second line after resistance to EGFR TKI first generation for patients who presented EGFR T790M mutation. And the results are really clear. You can observe that there is an absolute benefit of osimertinib compared to the doublet of platinum for this patient with a PFS of 10 versus 4 months and the hazard ratio at 0.3. So I hope you are convinced that when you have a resistance by T790M after EGFR TKI first or second generation, you should utilize osimertinib for this patient. What happens if you have brain metastasis? So osimertinib has, as you can see, a quite good penetration in the brain, so it can be used for brain metastasis, and the results appear to be concordant with that. You can see over here 2 different curves, the patient with brain metastasis and without brain metastasis, and you can see that the benefit, the curves are very similar with the osimertinib, whatever you have or you don't have brain metastasis, and the results are very similar as well. So it can be used for patients with brain metastasis. Another demonstration over here, this is a pooled trial of ORA. And, oh, this is in French, sorry. So, this is a little mistake. And I can see here that the response rate for patients with brain metastasis was 54%. Unfortunately, as we would expect, the patient that responded to osimertinib will afterwards develop resistance to osimertinib as well. As the research is going really quick right now, the mechanism of resistance are already known. So there are mechanisms of resistance that are depending on EGFR, and there are other mechanisms that are independent of EGFR. The ones that depend on EGFR include the disappearance of T790M mutation and appearance of different mutations that are called tertiary mutation. And also there are again HER2 amplification, MET amplification, or FGFR1 amplification, or also the transformation in small cell again. And the 4th generation of EGFR TKI is coming. We have preclinical data that are very promising, and we are, of course, waiting for the clinical data. What would you do with a patient with other resistance mechanisms than T790M? So for the ones that are T790M negative, so you can see here in the AURA trial that the T790M had only a response rate of 21% and a PFS of 2 and 8 months. So we should not recommend to use osimertinib for the T790M negative patients. So what do you propose for this patient? You propose to keep the same treatment that you were doing before having osimertinib. So you keep a chemotherapy and you add or not bevacizumab according to the country where you work and the recommendation of your country or reimbursement for the drug. I've been personally working in 2 different countries, Belgium in Europe where bevacizumab is not reimbursed, and France in Europe where bevacizumab is reimbursed, so it varies. And then you need to think also when you have a small cell transformation to use a doublet platinum and etoposide, of course. And for your patient where you would detect an amplification or MET, think about including them in trial with MET inhibitors. Would you continue EGFR beyond progression? This is a question that has been asked in the ASPIRATION trial. This is a phase 2 trial, not randomized. Investigators were allowed to continue with EGFR beyond progression, and so they measured the PFS1, which was the first progression step, and when patients were continued on EGFR, they had a second PFS that they were calling PFS2, and you can see that for the patient that could benefit from this continuation of EGFR beyond progression, there was an improved PFS when they finally stopped the drug. So we may say that for patients which are progressing really slowly and that tolerate really well the drug, you may continue EGFR beyond progression, saying that then you're waiting longer to use your second weapon, which is finally osimertinib if ever they are T790M positive or something else. How do you manage a EGFR-mutated patient at the time of progression? You need to be sure first that this is really a progression and the resistance, and precaution with bone metastasis because they are difficult to evaluate in this patient on the imaging. If you have brain metastasis only, you need to consider to continue the TKI EGFR. I could not show detail about that because of the time of the presentation, but you can do local treatment for the brain metastasis. In case of oligometastatic progression outside the brain, you can also continue TKI and do local treatment. If you have a slow progression, you can consider continuing TKI and then do a very close follow-up. But if there is a real progression, you should change the treatment, go for TKI third generation, c-MET inhibitor, or chemo. And of course, never forget to rebiopsy your patient to identify the mechanism of resistance. I want to mention very briefly that sensitive mutation testing is possible both in the tissue and in the cDNA. Another speaker will go in detail for this, but there is a concordance of around 80%. The sensitivity is quite low, 75%. The specificity is really high. But you can predict the response to treatment by using cDNA testing in the same way than by tissue testing. As you see here, the T790M positive in the blood had a way better response than T790M negative in the blood. This is true for exon 19, exon 21, but also for T790M, where the sensitivity is still a little bit lower than for the two sensitive mutation. There we can recommend, based on that you would do first cDNA testing at resistance to EGFR TKI first or second generation for your patient, because the test is approved by the FDA. If it is positive, you go straight ahead, you prescribe osimertinib. If this is negative, as the sensitivity is really low, you should check by tissue biopsy. And if it is positive, then you go for osimertinib, and if it is negative, then you give chemotherapy. So what are the perspectives? We don't know yet the exact role of immunotherapy in EGFR-mutated patient. The first study showed a lower response rates in this patient, but we don't know what would be the strategy. Maybe we should give them chemotherapy and then immunotherapy. So there are still options for this patient, maybe in the future with immunotherapy. We don't know yet what will be the future of the combination of EGFR TKI with bevacizumab in first line. We don't know either what we will do with the combination of EGFR TKI and EGFR monoclonal antibody in first line. Other combination may appear as interesting. And also there is now the introduction of EGFR TKI third generation in first setting, as the FLORA trial, for which the results are really awaited, is now comparing osimertinib to erlotinib or gefitinib in first line setting. So in conclusion, what do we do now? In first line today, we prescribe first or second generation TKI, and afterwards we follow it by chemotherapy or third generation TKI. Potentially in the future, we may associate the first or second generation drug with an anti-angiogenic molecule, and then follow again by chemotherapy or TKI third generation. We may start in the future by the third generation directly, and we may even start by an association of the third generation with something else. I thank you for your attention.